Hello, my name is Dr. Zhenya Krepovinsky, and I am faculty with the Department of Hospital Medicine at the University of California, San Francisco. And today, I want to talk to you about alcohol withdrawal in the hospitalized patient. The primary goals of today are for you to be able to recognize the different stages of alcohol withdrawal among hospitalized patients, to be able to use a standardized tool called the SIWA score to determine the severity of alcohol withdrawal, and to feel comfortable prescribing medications to treat alcohol withdrawal among your patients. Most patients with alcohol use disorder do not ever go through withdrawal. However, alcohol withdrawal syndrome is more common among persons with alcohol use disorder who are hospitalized to the medical and surgical wards or who present to the emergency department. And so, among my patients who I identify as having alcohol use disorder, I am very careful to ask them about the timing of their last drink and to screen for symptoms of alcohol withdrawal. A second scenario where I always remind myself to think about alcohol withdrawal is when I'm evaluating a patient who's been hospitalized, who was previously oriented, who suddenly becomes confused, usually 1 to 2 days after admission. Now, the symptoms of mild alcohol withdrawal occur 6 to 24 hours after a chronic alcohol user has the last drink, or 6 to 24 hours after they suddenly decrease the amount of alcohol that they drink. Symptoms of minor alcohol withdrawal include anxiety, insomnia, upset stomach, headaches, palpitations, anorexia, as well as tremor, which is characteristically an intention tremor, sweating, and tachycardia. So, what do all of these things sound like to you? Yes, it sounds like a really bad hangover. That is exactly correct. This is because, in large um, amounts, alcohol is a depressant. So, therefore, symptoms of alcohol withdrawal result in sympathomimetic excitation, which results in tremor, sweating, palpitations, as well as a rapid heart rate. Now, most patients who have alcohol withdrawal would only experience mild symptoms. However, about 20% of people with alcohol withdrawal will go on to develop what we call severe alcohol withdrawal. This is characterized by hallucinations, seizures, and can progress to life threatening delirium tremens. In persons with severe alcohol withdrawal, hallucinations typically develop anywhere between 18 hours to 36 hours after they have their last drink. Most of the time, these hallucinations are visual hallucinations, although rarely they can have auditory and tactile hallucinations as well. So, how do you figure out which one of your patients it has alcohol intoxication and psychosis versus alcoholic hallucinosis? The key distinguishing feature here is that in alcoholic hallucinosis, patients almost always report specifically visual hallucinations. In my experience, most commonly reported symptom is that they see bugs in their room or can see insects crawling on their body. In patients with psychosis, either from other drug use or from organic brain problems, more commonly experience auditory hallucinations. And in patients with withdrawal from alternative substances, such as opiates or methamphetamine, tactile hallucinations are more commonly reported. Now, as this alcohol withdrawal syndrome progresses, patients can develop alcohol withdrawal seizures. These are typically generalized tonic-clonic seizures. They rarely last more than 3 minutes, and the greatest risk of experiencing a seizure occurs 24 to 48 hours after somebody's last drink. Now, if a patient has a history of alcohol withdrawal seizures, they're most likely to experience this again. And so I always ask my patients if they've ever experienced a withdrawal seizure in order to keep myself alert to monitoring for escalating symptoms of alcohol withdrawal in day 2 to 3 after hospitalization. Now, in patients who experience an alcohol withdrawal seizure, especially if it's for the first time, it's important to rule out alternative causes of seizures. Most commonly, these would include a subdural hemorrhage or a traumatic brain bleed or brain trauma from a fall during intoxication that is now serving as a seizure focus. Therefore, in my patients who have alcohol withdrawal, if it's a first time seizure, I always obtain a head CT to make sure there's nothing else going on in addition to treating them. The most dreaded complication of alcohol withdrawal is a late onset symptom called delirium tremens. Typically, this occurs in day 3 to 5 after the patient's last drink and is associated with up to 20% mortality if left untreated. Delirium tremens is a combination of alcoholic hallucinosis, but paired with confusion as well as abnormal vital signs. So it's important to remember that patients can have alcoholic hallucinosis and not have delirium tremens. But if they have hallucinations and are also not oriented to person, place, and time, and have severely deranged vital signs like severe hypertension, fever, and severe tachycardia that you're unable to control with benzodiazepines, they are likely experiencing delirium tremens, a life-threatening condition that almost always requires admission to the intensive care unit. So again, DTs are characterized by the rapid onset of altered sensorium, hallucinations, and abnormal vital signs in a patient with alcohol withdrawal anywhere from 3 to 5 days after their last drink. And the difference between DTs and alcoholic hallucinosis is the presence of confusion as well as severely deranged vital signs. This is a life-threatening condition which we try to avoid by treating alcohol withdrawal. So, how do you treat alcohol withdrawal? I like to use IV or oral benzodiazepines to prevent the development of DTs in patients with alcohol withdrawal and to minimize their psychomotor agitation. I use the SIWA. The SIWA score is a validated tool used to evaluate and assess the severity of alcohol withdrawal in a patient. I use it to guide my medical management, as not every patient with alcohol withdrawal will require medical therapy. The CIWA score is an assessment tool that can be done by the physician or the nurse to evaluate a patient based on the following criteria: nausea, vomiting, tremor, sweating, anxiety, tactile, auditory, and visual disturbances, the presence of headache, agitation, as well as orientation. The maximum score that one can get on the CIWA scale is 64. Scores greater than 8 require medical treatment. So, how frequently should somebody receive a CIWA score assessment? We say that if a CIWA score is less than 8, a patient should be reevaluated every 4 to 6 hours until their score is less than 8 for 24 hours in a row. For CIWA scores between 8 and 24, an assessment done every 2 hours is recommended. For a CIWA score that's greater than 24, we typically recommend that patients be monitored in the ICU, as continuous evaluation of their mental status as well as their vital signs is typically necessary, in addition to infusions of benzodiazepines. In order to obtain the full CIWA assessment tool, I go to mdcalc.com and type in alcohol withdrawal or CIWA. This is the link provided. It lists all the questions that you should ask a patient or instruct the nurse to ask with the appropriate grading scale. Once comorbid illness has been excluded, I initiate the medical treatment of alcohol withdrawal when a patient's CIWA score is greater than 8. I tend to use benzodiazepines in order to control the psychomotor symptoms of alcohol withdrawal and to prevent mild alcohol withdrawal from progressing to severe alcohol withdrawal. Typically, long-acting benzodiazepines are preferred, such as chlordiazepoxide, otherwise known as Librium, as well as diazepam. These are typically preferred because of the smoother clinical course and the lower incidence of recurrent alcohol withdrawal seizures and delirium tremens upon cessation. However, not all patients are candidates to receive oral therapy, and IV diazepam is frequently in national shortages. Oral options for the treatment of alcohol withdrawal include chlordiazepoxide, otherwise known as Librium. I start this anywhere from 25 milligrams to 100 milligrams, which I give orally to a patient whose CIWA score is greater than 8. I can repeat this dose every 4 hours until a CIWA score less than 8 is achieved. For patients who have severe underlying liver cirrhosis or who are experiencing acute alcoholic hepatitis, oxazepam is a safer option for oral agent. Oxazepam can be used at 10 to 30 milligrams orally and can be repeated every 4 hours as needed to achieve a CIWA score less than 8. Most patients who are experiencing tremors and all patients who are experiencing a withdrawal seizure should be treated with IV benzodiazepines. The options for this include IV diazepam, which can be given at 5 to 10 milligrams every 4 hours as needed to achieve a CIWA score less than 8, or IV lorazepam, which can be given at 2 to 4 milligrams every hour to achieve a CIWA score less than 8. Lorazepam is preferred in patients with severe liver disease, such as liver cirrhosis, or who are experiencing acute alcoholic hepatitis. It's important to remember that especially if using IV diazepam, very large amounts of diazepam can be needed in order to achieve patient comfort and receive a score of less than 8, up to 500 milligrams on the first day. If you're noticing that your patient is requiring such significant amounts of benzodiazepines that they're achieving sedation while still experiencing tremors when aroused or vital sign instability, it is appropriate to transfer them to the ICU for more intensive management, which could include infusions of benzodiazepines. The last thing I'd like to mention is that many emergency rooms throughout the country are now using phenobarbital as first-line treatment of alcohol withdrawal. This is done because phenobarbital has been shown to have a lower incidence of alcohol-related withdrawal seizures and delirium tremens without the need to have repeated administration. If phenobarbital is used, the typical regimen is 260 milligrams IV loading dose, followed by 130 milligrams IV as needed. It's important to keep in mind that if you use both phenobarbital and benzodiazepines together, your patient is at an increased risk for having respiratory depression, and this should be closely monitored for. All patients who are getting IV benzodiazepines or phenobarbital for the treatment of alcohol withdrawal should be placed on a monitor, and their oxygen saturation, respiratory rate, neurologic exam, and EKG should be frequently monitored. So, in addition to treating patients with alcohol withdrawal with either IV or oral benzodiazepines, supportive care includes giving all patients thiamine along with glucose in order to prevent the development of Wernicke's encephalopathy. This is most commonly given as part of a banana bag in the emergency department. IV thiamine should be continued for 2 days and then can be switched to oral thiamine daily for most patients with chronic alcohol use disorder. In addition, patients should receive daily multivitamin with a folate. All patients should get IV fluids until they're able to adequately take in orally, and their electrolytes should be monitored and repleted daily. After you've successfully treated acute alcohol withdrawal, all patients should be screened for alcohol dependence and considered at risk for recurrent episodes of alcohol withdrawal upon readmission. So, in conclusion, I want you to remember that alcohol withdrawal symptoms begin as early as 6 hours after a person with alcohol use disorder has their last drink. You can expect for day 1 to be dominated by mild symptoms that look like a severe hangover. But in 20% of patients, by day 2, hallucinations, which are usually visual and involve bugs, develop. Day 2 and 3, patients can develop delirium, alcohol withdrawal seizures. And then a late manifestation and a life-threatening one is delirium tremens, which is characterized by hallucinations, altered mental status, and severely deranged vital signs. And this occurs anywhere from day 3 to 5 after a person's last drink. Remember to include alcohol withdrawal on the differential of delirium of sudden onset in your hospitalized patients. In order to evaluate somebody who you suspect to have alcohol withdrawal, use the SIWA scale. It allows you to assess severity and guide treatment. Once a patient's SIWA score is greater than 8, start either IV or oral benzodiazepines in order to control psychomotor agitation and prevent progression to more severe forms of alcohol withdrawal. And when in doubt, you can always call the Poison Control Center at the number below to help you out, and especially in complicated cases or where multi-substance use is suspected. Thank you very much for listening to this brief presentation on alcohol withdrawal management in the hospitalized patient, coming to you from UCSF in partnership with New York City. We love you and we hope for the best for you.